You are listening to the global network of podcasters dedicated to the pharmacy profession. Welcome to the Pharmacy Podcast Network. Welcome to the Maternal RX podcast on the Pharmacy Podcast Network. I'm your host, Dr. Danielle Plummer, pharmacist and antepartum doula. This series is to empower pharmacists to help turn around the maternal morbidity and mortality rates, which now constitute a public health crisis. Pregnant women often fall into a hole in healthcare, especially in antepartum care, and pharmacists are perfectly aligned to fill this gap. We are the most accessible and trusted healthcare providers. And today I am so excited to have a guest on a topic that I have been waiting for a very long time to discuss, that is often discussed among every pregnant woman that exists and their obstetrician. But now we're bringing it to the beginning of pregnancy and throughout the pregnancy and talking about the various types that exist. What am I leading up to? Diabetes. And our special guest today is Dr. Tade Vartanian, who serves as Sanofi's field medical expert for autoimmune diabetes. Before joining, Tade worked at various hospitals in Southern California as a clinical pharmacist, pharmacy supervisor, and later a pharmacy manager at institutions such as CHLA and UCLA, among others. Tade saw the impact a delay in disease onset could have on patient care and how that follows the patient's journey in the healthcare setting. Tade enjoys discussing all things medical surrounding screening, clinical trials, new research, guidelines, and any other opportunity where medical understanding can make a difference in patients' treatment before diagnosis. And Tade, why this is so exciting to me is because we often see the ads on TV or now your computer, social media, at your pharmacy, what medications are available, but very rarely do I see clinical trials on these medications. And when we talk about diabetes and pregnancy, again, we have type 1, type 2, gestational. You're going to talk about a type I haven't heard of, and I'll leave that to when we get to it. What happens before pregnancy, during pregnancy, following pregnancy, and how all of these different types of diabetes can affect a pregnant patient and their family who's on that journey as well. So please share anything I left out about the work you do, and we'll get started on this topic.
Yes, well, absolutely, Danielle. First off, thank you for having me on the show. This is something that everyone who's listening will probably maybe ask, what does this guy know about just the gestational diabetes, let alone type 1 diabetes, type 2 diabetes, and off the list? I think for me, when I started my clinical pharmacy practice, the thought initially when we had the diabetes education, right, in school, it's the medications, it's the disease state, it's the condition, and we kind of learn it. But I think diabetes almost became, in my clinical practice, one of those most minute to minute, hour by hour, day by day kind of condition, where it's all it became a numbers game. It became a very much like detail oriented condition. Not to say obviously the other conditions aren't like really meticulously like that, but I think diabetes is up there. So I think it's really interesting that, for the past year, I served again as the medical lead for autoimmune diabetes, really honing in on that condition and kind of seeing the periphery within, the other kinds of diabetes. I think one of the biggest lessons we can take probably at the end of this is, what is autoimmune diabetes? What are the other conditions for the different types of diabetes, and really how to distinguish it? Because, sneak peek or fast forward, even the clinicians could sometimes get that wrong. So would love to dive in.
Especially because so many clinicians are not working with this specialty specifically, but the patients are seeing all types of clinicians. And that's the unique thing about pregnancy, is that it crosses so many different disease states, yet obstetricians are the main provider. These patients aren't seeing them if it's a first pregnancy, often till 10 weeks into the pregnancy. We have maternal care deserts where there aren't obstetricians. You may now be seeing a resurgence of midwifery in the United States. There's this huge need, but which type of midwife you are depends on what state, what licensing there is. You're going to see different initials after their name. Now, doulas are, while they're not clinical, are a support person that are slowly being covered by insurances, often at labor and delivery where it is much needed. But then there's those rare people like myself that are saying, hey, we have this first trimester that's been ignored that we could potentially use to prevent things from escalating later in the pregnancy. So I want to begin. You said, what is autoimmune diabetes? What is autoimmune diabetes? What are we referring to here?
Yes, absolutely. So diabetes, just as a blanket term, is really any condition where there's basically a dysregulation of someone's glucose levels, blood sugar, i.e., glucose. So many of us have probably heard of type 2 diabetes. Everyone usually, if it said diabetes colloquially, they're often referred to as type 2 diabetes, just off the top bat. And for good reason. There are about 38 million type 2 diabetic patients in the United States. And that number keeps on rising. And then that's also not including the pre-diabetic individuals. So type 2 diabetes is what's mostly defined as insulin resistance. The body's muscles, the liver, the various organs that kind of serve as glucose sinks, and to have that response to insulin, their insulin response is weaker. So in type 2 diabetes, it's really a long-term, oftentimes slowly progressing condition where there's a strong level of insulin resistance, and hence the body is able to produce insulin. The function is still there, but the way that the insulin works on those organs is, altered in some way, shape, or form. Now, to answer your question, obviously with type 2 diabetes, the question is, well, what happened to type 1? So type 1 diabetes is the one that's termed as autoimmune diabetes. That T1D, as well as called, affects about 2 million people in the whole US. It's about 5% or so of the whole diabetic population, about 5% are T1D. And that's what's called autoimmune diabetes, where the patient's own immune system, right? The immune system that's used to fight off infections, of bacterial, viral, and so forth, goes against one's own body. So if that autoimmune process attacks the thyroid, that can be autoimmune thyroiditis, which also actually is increase in rate during pregnancy. If it attacks the adrenal glands, it's called Addison's disease. The skin, it's called vitiligo. So in diabetes, in type 1 diabetes, the attack or the target is the beta cells within the pancreas. Beyond that, there's also a whole host of other diabetes cases as well. Monogenic diabetes, it's about 1% of the population of all diabetes cases. And that actually is a area of research, right, to differentiate and to see what's going on for there, and a whole host. But yeah, that's T1D in a nutshell.
And now, when we talk about pregnancy, gestational diabetes
Yeah.
is something that's a big concern. And what I had learned, because I work with so many patients with hyperemesis gravidarum, so they're not eating anything, yet they're still susceptible to gestational diabetes, which sent me down a deep dive going, what is causing this? And learned it's hormones being secreted from the placenta that's changing this. But before we talk about that, I want to circle back to some of the things you just said. So, type 1 diabetes, when I was a little girl, I had a friend who had type 1 diabetes. We were both very young, elementary school, and I remember her having to give herself insulin shots. And my mind was blown because the thought of me at the time looking at a needle was a nightmare. And there she was, just always, as a young child. And we're still friends decades later, and she's doing very well in life. So, this is type 1. I feel just, for anyone who has to deal with this, it's a way of life, right? And it is their life. And when I know parents who have children with type 1 diabetes, their world changes. As a parent, you're always concerned for your child. But with the right care and management and tools, this is something that you can have a wonderful, healthy life with. Type 2, as you mentioned, is lifestyle, potentially, right? It happens later in life. And often we're seeing it now more type 2 in younger children, unfortunately. And when we think about women of childbearing age who want to become pregnant, that dysregulation can also affect the ability to become pregnant. And I've seen women where they have type 2 prior, they want to have children, they get their weight under control, make healthier food choices, lifestyle choices. The idea of carrying another life into this earth that has made them change their own habits to be healthier, and it's nice to see that when that happens, and then to see those habits continue as well. When I was growing up, we were told, yeah, this is aging myself, but we were told, eat like what, 2 to 4, 4 to 6 times a day, 3 meals and 3 snacks, and every 2 to 4 hours. And what we've seen now since the 1980s is this has done so much damage because we're constantly taking in glucose. Our body is constantly trying to produce insulin to break down the glucose, get it into the cells to work. And it's led to this, what you talked about, insulin resistance. So we have type 1, we have type 2. What is monogenic diabetes? Because that's a phrase I have not heard before.
Yes. So, and this is all, you mentioned something interesting, Danielle, with regards to the individual who's pregnant, right? A pregnant
Hmm.
individual. Now, there's a wide window for which women get pregnant. And I'm sure I can always look up like what's the youngest pregnancy and what's the oldest pregnancy. And I'm sure that's
Mm.
going to be a wide window, but let's
Hmm.
picture the very typical, 95% bell curve of an individual getting pregnant. The interesting thing about that is they're kind of in a situation where if they develop diabetes, right, it's really important for the clinician to distinguish what type it is. Is it gestational diabetes? Is it type 1, type 2? And to add to and touch upon what you just asked, monogenic diabetes. So monogenic diabetes, as the name is kind of hinted in there, is diabetes that is a result of a single gene mutation. Now, it's actually a consortium of about 15 to 20 different types of monogenic conditions that all in all, from an umbrella term, is called monogenic diabetes. Again, it's about 1 to 2% of the entire diabetes category. But one important thing I learned in getting, really focused in diabetes care is when something is about 1 or 2% of cases, it's really hard to diagnose and it's really easy to miss, right? So there are a lot of monogenic diabetes patients who were initially labeled as type 2 diabetes, and then maybe the clinician may have thought, oh well, maybe it's transient, and until they get to like a really specialist, are they able to do, let's say, the genetic tests to see, okay,
Mm.
is there an allele, what is the genetic profile, and to basically screen for about a dozen plus different genes, and if one hits as positive, it's considered monogenic. And depending on what monogenic diabetes type they have, the treatment is fairly straightforward. Most of them are actually treated with insulin. There's actually a certain type of monogenic diabetes that's only treated and responds really well with sulfonylureas, for example. So
Mm.
the kind of takeaway from there is if there's some, case of diabetes that's just odd, not responding well, it doesn't paint that right picture, it doesn't respond to a whole lot of, therapies, it might be worth it to get it screened. And that's really, again, a genetic test that will be determined. And there's also a calculator online that one can use and type in certain criteria to kind of paint the clinical picture. Is it more monogenic or not? To give anyone who searches monogenic diabetes calculator can probably find it.
I have heard people, and I want to say the past 10 years or so, talk about what they're calling a type 1.5, where they're adults, but they're getting the autoimmune type. And I'm wondering if maybe it is the monogenic that was just
Mhm.
difficult to diagnose. So
Yeah.
interesting to see where that will lead, and love what you talk about. Let's talk about clinical studies. And what are you seeing now? What's being studied for patients with diabetes?
Yeah, absolutely. So type 2 diabetes has really had its time under the sun, right? There are a whole host of different pharmacological agents that have come out, right? The thiazolidinediones, the SGLT2 inhibitors, and you go down the list of different types of, products that are out there and different choices that are out there. And the reason is because, again, remember, type 2 diabetes is a very insulin resistance type of diabetes. And again, it's a very large population. So there's different ways to treat it. Now, interestingly, type 1 diabetes, as you kind of mentioned earlier, Danielle, growing up, you had a friend, in the childhood years who had type 1 and they were injecting themselves with insulin, right? What's interesting with type 1 diabetes is that historically, um, originally it was called juvenile diabetes because it was thought that only autoimmune type 1 diabetes can only happen in children, in kids, and it didn't happen in adults. Well, the reason why that whole theory kind of came about was because really many of the tests that were used to determine diabetes just in general was, right, the hemoglobin A1C, a fasting glucose. I mean, if you turn the clock more back, urine glucose tests were the only options. And there was no what are called autoantibody tests that were really available in clinical practice. So what ended up happening was a lot of adults actually were developed type 1 diabetes even back then. But because adults who develop T1D tend to have a slower progression of the diabetes condition, as opposed to children who get T1D and the disease progresses really fast. Adults are a little slower onset. Adults tend to also have a little bit more waxing and waning of their autoimmune condition. And that's true really for all kinds of autoimmune conditions. If you look at lupus in children and adults, if you look at celiac in children and adults, it's a very different picture. The children oftentimes progress much, much quicker and in a fairly straight linear format. Adults progress a lot slower and they may go, relapsing, remitting, non-relapsing, and so forth. So that's kind of for the adult picture. So juvenile diabetes is kind of no longer used because now we found out a lot of adults have type 1 diabetes. And so for that gestational patient, it's going to be an interesting case because, there's a portion of pregnant individuals who are seeking medical care maybe for the first time in their lives. So there could be this thought that they were already diabetic for several years, but they're just now seeking medical care. So that's like one scenario. The second is obviously it could be gestational diabetes. But again, they're right now at that prime age of the teen years, in their 20s, in their 30s, where that autoimmune diabetes can really start and kick off. And with pregnancy being a sort of pro-immune kind of state, if you will, right? The mother's immune system is adjusting quite in a much different way than obviously pre and post pregnancy. It's not just weight gain; it's a complete immune shift in that individual. Then that could be the opportunity or the setting, if you will, where we really need to look at autoimmune conditions. And so my recommendation for all pregnant individuals who may have to experience or come across a diabetes case is let's always also consider or at least bring up the conversation of T1D. And the beauty is that, we can screen for it now.
We're really changing the script on how we talk about diabetes and pregnancy. I've never heard anyone say, let's screen for type 1 in this age range, in this patient population. So thank you so much for bringing that to light. Type 1 diabetes screening, what would that entail? Is it the same as type 2? We know gestational screening is different. So what would you share with that?
Yes, absolutely. So a patient who has type 2 diabetes, because again, as we discussed, this is a fairly slower progressing diabetes case, relatively speaking. So for the most part, checking someone's hemoglobin A1C on an annual basis, if they're high risk, we can go like every 6 months. In other words, glycemic measures are what's used to, one, diagnose the diabetes, but also two, to monitor it and to catch. What that means is if someone's A1C is normal, their fasting is normal, everything looks great on the glycemic end, that's a fairly good enough marker for monitoring those individuals clinically in the real world, right? To see if they are at risk or do they have type 2 diabetes. Now, with type 1 diabetes, because it's a faster progressing, oftentimes condition, especially in children, historically, the same measures were always used: A1C, fasting, and maybe some individuals, if they had a first degree relative with type 1, maybe the clinician would just measure and monitor a little more frequently. But the interesting thing with what are called screening measures is there's actually, and not that new, it's been around for quite a while in the research setting, and it's really getting traction in the clinical setting, is measuring for autoantibodies. Now, what autoantibodies are is when type 1 diabetes occurs and there's that autoimmune reaction, the body is attacking its own pancreatic beta cells, right? They're the ones being killed off. Well, just like how the body kills off a Staph aureus infection and forms antibodies towards a Staph aureus infection, as a way of memory immunity, when the body attacks the pancreatic beta cells, it forms antibodies to the beta cell antigens as a form of memory, right? It's just how the body's immune process works. And so when those autoantibodies are formed, what we can actually detect those through a blood test up to 10 years before actually the T1D condition manifests itself. Because that autoimmune process has started, it's being attacked, and those antibodies are forming. And the patient really develops type 1 diabetes when about 70 or 80% of the pancreatic beta cells are already killed off. That's when the patient actually feels something. But 5% gets killed off, 10%, 20%. Those antibodies are there. The patient still feels fine. So that gives us a really many years of a window of opportunity to test for these. And there are 5 autoantibodies to test for. It's all ordered in a panel to really catch those patients early.
And would patients go to an endocrinologist for this, or how would they even know to go about to get the screening done?
Right. So this type of screening can actually be ordered by any clinician, primary, OB-GYN, any clinician can order it. Most health plans or health system won't have a restriction to only endocrinology to order the test. But it is a test that the patients would have to ask up and request. A lot of individuals who may have a first degree relative of type 1 diabetes can and often do this because they know that they have a genetic risk to develop T1D themselves. But even those who don't have a genetic risk to develop T1D and don't have a first degree relative, the chance is still there. And so if the patient speaks up and asks for that test, they can do it. And there are multiple ways to get the test done. What I refer to is commercial labs. So the physician, their primary, the OB-GYN, and then they order a test through a commercial lab. But there are also various organizations and ways to get tested that I can definitely go over as well. And some can even send kits to your home as well to do that.
Yes, that's a dream for most pregnant women. Anything that can be done in the home, if you don't have to take time off from taking care of other children or take off from work, or if you're not feeling well, especially early in pregnancy, which is where you would want to identify this to be done at home. Yes, please go ahead and tell us about these tests.
Yeah. So first, if you have a first degree relative who has type 1 diabetes, as well as up to a second degree relative, and I believe the age cutoff is 20, there's an organization called TrialNet. So TrialNet is a nonprofit organization that's a consortium and developed by the NIDDK, which is under the National Institutes of Health organization. Bottom line, it's a consortium of various hospitals, health systems, and academic centers that do specifically type 1 diabetes research. So individual can actually go on the TrialNet site. They can, put in all their information and get an at-home test kit sent to them. Again, that's for individuals who have a first degree relative. They do a finger poke stick, put blood in a dried blood spot or a DBS, those kind of cardboard-like placards, mail it out and get the results. The other way is through the Autoimmunity Study for Kids, the ASK program. And it was called ASK K for Kids because initially it started off for children, and it has since expanded into adults as well too. So adults can get autoantibody screening for kids and for adults as well. That is also done through the University of Colorado, but they can send out these test samples throughout anywhere in the United States. Again, the kit is mailed to the individual, blood spot, put in the card, send it out, and get the results. And that one is unique because the first degree relative is not a requirement piece to get that. So anyone in the general population could just pop in and do it. So yeah, there's ways to do it.
So let's turn now to gestational diabetes. This is, to me, the meat of the topic because pregnant women get poked and prodded and put through so much. And here they get to this time in their pregnancy about halfway through, and they're told you have to drink huge amount of sugar. There are some alternatives, but there's not agreement on those alternatives from ACOG and the overseeing agencies. It is well known how important it is to identify pregnant patients with gestational diabetes and what can happen through the pregnancy and their soon to be child if they're not diagnosed and treated from this moment in time. But I would love to hear, what are your expert insights on the gestational diabetes testing?
Well, you've referenced a couple pieces on that, Danielle. First is just the difficulty of taking these OGTTs, oral glucose tolerance tests. Again, they're a test that's to be done during pregnancy, but again, because during pregnancy, to consume a large glucose load and wait for a period of time while the measurements are done on the glucose end of things, a lot of individuals and patients one are not able to do it just physiologically. Second, they just say, I don't have time because hey, I have two other kids. I'm on my third pregnancy. I don't have time. The other piece, obviously, is that just from the convenience aspect, it's a big ask for patients. And then kind of the fourth piece as well, it's a big piece for the clinics as well too. Many of OB/GYN clinics naturally will have a certain number of chairs, a certain scheduling structure that's needed. So to kind of book a several hours piece for a patient, that does require some scheduling and coordination too on their end. The other piece you mentioned is different societies have different recommendations. So like ACOG, the American Diabetes Association, U.S. Preventative Services Task Force, all these organizations discuss and talk about the need for gestational diabetes diagnosis testing, but they all may have different recommendations. Some say, do the one-step 75-gram load. Others say do a two-step. There may be also some pieces in betweens as well. But bottom line is there's some differences in the recommendations, and there's no consensus among the organizations on the best single test because they always have to balance being able to be clinically, valid while also balancing patient convenience piece as well. I would say one thing is many patients ask, why do we have to actually do this, right? The A1C is measured. I go in for my annual check. Why is this have to be the way to be measured? And the short answer is the oral glucose tolerance test, technically speaking, is the gold standard for all cases for diabetes diagnosis. So per the ADA guidelines, diabetes can be diagnosed in a few different ways, whether it's a hemoglobin A1C, a fasting glucose, or the OGTT or oral glucose tolerance test, and specifically the glucose level at the 120-minute mark or the 2-hour mark. And so technically, with regards to how well it's correlated, the OGTT technically is the best gold standard. And the way that the A1C and fasting glucose can be kind of used or gone away with is because if someone's doing it every year, even though there are some inaccuracies and maybe some issues, and is the patient really fasting, and is the last 3 months really indicative of a patient through their A1C? Bottom line is because they're getting their glucose checked every year, those kind of imperfections sort of level out, if you will. But since the OGTT is the one time and the one hit that we can get to catch that gestational diabetes, they go with the OGTT as the recommendation.
That actually explains a lot why that's used in guidelines for every pregnant patient. It is the gold standard. We talked about how much is the glucose load in that can of what looks like orange soda, right? Which we're told as pregnant patients, don't drink soda or minimize how much, like maybe one a day. And then here, drink this massive load. Glucola comes as either 50 grams, well, you mentioned the 75 or 100 grams of glucose, depending if it's the 1-hour test or the 3-hour test. And what's important is that you do get tested. Ideally, when you find out you're pregnant, get a diabetes screening test done right away. So we can then, if somebody is at risk or does have undiagnosed type 2, or as you mentioned, this type in between, right? We can identify those patients early on. And then when they're halfway through the pregnancy, we can go ahead and find their risk. And if they do come back positive or borderline, which happens to many women, we can get that patient under specific care to their needs and make sure that the best outcomes are in line for them in that pregnancy. If it goes undiagnosed, the outcomes, they can just be very scary for both mommy and baby.
Yeah, absolutely. Absolutely. The earlier, the better. But naturally, to throw something at you, Daniel, and maybe ask you a question as well, is
Yeah.
my understanding is first trimester is oftentimes the most when patients may experience nausea and emetic, symptoms. What are your thoughts on that in that setting? You know,
Then you're touching my heartstrings here, right? Having had 3 pregnancies where I suffered from severe nausea and vomiting, known as hyperemesis gravidarum. I mean, for me, when they told me I had to drink this glucola, like there was no way I was keeping that down. It was just pure torture. That first trimester, guidelines were created many, many, many decades ago, where ideally there's not much you can do in the first trimester. Now we know better. And ACOG did just recently update their guidelines to say it's not one size fits all when you should see an obstetrician from the time you become pregnant to the time you deliver, and post-op care, which is pretty much non-existent in the United States. So now we're looking at this first trimester. And what I learned, what I mentioned earlier, was that if I am vomiting everything, I'm not keeping any food down, how could I be borderline gestational diabetes? And that happened actually to me in my 3rd pregnancy. Did not need insulin, fortunately, but it sent me down this like rabbit hole of information. I see now many women posting in support groups online asking the same question. I'm not eating anything. I can't keep any food, any nutrients. I'm malnourished, yet I'm told I'm borderline or I have gestational diabetes. Like, how is that possible? And from what I found, it's hormones that are being secreted from the placenta. Even knowing that, it's not a matter of changing your diet per se, but getting under the right care. And if you need treatment at that point or monitor more frequently, as you had mentioned, starting earlier in the pregnancy, by the time you hit that 20-week, then you should be in good shape, better shape. If we use the right IV therapies, nutrition, antiemetics, as you mentioned, other supportive care therapies, maybe we can use nutrients in a way and lifestyle to help prevent this from escalating. But knowing it is from the placenta, those patients where the other modifications are not going to make a difference, they need insulin. The sooner they get that care, the better off both mom and baby are going to be.
absolutely. I'm not going to add more to that and couldn't agree more.
Thank you so, so much. So, diabetes care in pregnancy in general, Tade, is there anything we missed that you would like to add?
Yeah, I think with regards to, the other piece as well too is you kind of touched on, right, maternal health. And obviously just by the extension of that, it's the child's health, right? So there's a whole host of data, and there's always more coming up with regards to the impact that the glucose level and the glucose load would have on the child's weight, risk of complications, risk of blood loss, percentage of C-section, all those kinds of like markers, if you will, at the end. It's always correlated. So I think that's the always big thing that we always want to look at is sometimes we always just want to treat the number and the glucose level, and that certainly has the impact right downstream to remember that. I think the other important thing to always remember with regards to anyone who has, whether it's gestational or again undiagnosed type 2 or type 1 that's sprouting out, is the risk of hypoglycemia. And oftentimes that's not discussed as often as hyperglycemia. So one thing that we learned actually with regards to glucose monitoring, let's say individuals who wear a continuous glucose monitor and what the guidelines are shown from there is, if you look at the recommendations on where someone with diabetes, what their range should be, interestingly enough, they say time in range is great and it's important. And what's interesting is they give about a 25% allotment to being in hyperglycemia and about a 5% allotment for being, or less, for being in hypoglycemia. So I think that's always, going back to what we said earlier, diabetes is a numbers game, and it's a very like detail oriented kind of condition. And again, that's the other big thing that we always want to hear and be careful with, because individuals who are pregnant are already at risk for, let's say, a fall or lightheadedness for conditions outside of diabetes. And now if you add diabetes, there's also that risk for hypoglycemia for patients to also be careful with as well too.
You brought up an amazing point. I have never heard anyone just in conversation or on pregnancy support forums or in the medical community in general talk about hypoglycemia in pregnancy. Thank you for bringing that to light. And it reminds me of one of the patients I was working with hyperemesis. She was on metformin prior to becoming pregnant. when she became pregnant, had this horrible disease, couldn't keep anything down, also could not keep her medications down. And she was so worried about having high sugar levels because she couldn't take her metformin. When she actually went into the hospital and got testing done, she was hypoglycemic. Had she been taking her metformin, she would have dropped even lower, even worse. And something to keep in mind. So, as you brought up and asked about, well, what about that first trimester? If you're sick, I mean, up to 70, 80, 90% of women have some nausea, at least in that first trimester. How many go on to have extreme versions? I've seen anywhere from 2 to 10%. Your medications might need adjusting during that time and throughout each trimester. And as you mentioned, this plethora of testing that should be done. Again, circling back, let's get this care, the screening done early, preferably even before you become pregnant. If you're in the planning phase to become pregnant, please do put glucose testing, sugar levels on your list of questions to ask your provider about. I have a question for you that I meant to ask earlier. What are your thoughts on continuous glucose meters or using a patch to monitor sugar levels in pregnancy?
Yeah, that's a good question as well, Danielle. Over the last several years, continuous glucose monitors or CGMs have just massively exploded in terms of their use and utilization, both in type 1 as well as individuals with type 2 and other diabetes, as well as individuals in the health and wellness space as well, for kind of that, really detail-oriented health monitoring, type of persona, if you will. Personally, I think it's a wonderful idea, right? Because just think of what diabetes technology, how it all started in the 1920s when insulin was first isolated from animal sources. As the whole diabetes technology is kind of the epitome of what medicine can do, and that it is a process, but that each year, each decade, things do improve, and the types of insulins that are available. Again, as I mentioned, before glucose meters, let's say, that are available, there were glucose strips, and type 1 diabetic patients used urine glucose strips to monitor their glucose in real time, which, as you can imagine, is just, you're not going to get anything accurate, let alone time appropriate in terms of what's going on at that moment. Bottom line is, we're at that era where now continuous glucose monitors are available, and they provide a plethora of data, not just in terms of just the numbers, but if you really think about it, we can have a patient come in with their hemoglobin A1C fantastic, right? 5.4%. And they can also come in and their fasting could also be great too. But what if their glucose just goes up, down, all the time? Or, I actually had a very good colleague even tell me this is an interesting story of, there are some individuals who, they culturally, they don't like to eat alone. They love to eat with a family as part of their culture. So they actually have very low calorie intake during the week, and then they have a big calorie intake during the weekend when family is over. And so those individuals, glucose will have perfect A1C, they'll have perfect fasting, but their glucose management is actually quite horrible because they're in hypoglycemia, and that's just not caught. The CGMs catch that because it's day by day, hour by hour. It updates a lot of them every few minutes. Now, the thing is, the American Diabetes Association still requires a diabetes diagnosis with the fasting or A1C or OGTT. So diabetes diagnosis can't take place with a CGM, but it's a great indicator for someone to be on, and that if the clinician sees something, to follow up with appropriate tests. I personally like it.
I actually tried it out. There's a couple manufacturers that came out with over-the-counter versions. You don't need a prescription for them. Knowing I had borderline in my third pregnancy, I am at higher risk for diabetes later in life. So just wanted to make sure everything was good. And the results were quite fascinating. They don't have the capabilities that somebody with a prescription does have, but they're brand new to market just within a year now. And the way technology is evolving, I think good things are to come. So I just looked up ACOG's guidelines, and they still recommend traditional blood glucose meters, so the finger stick ones, for monitoring, and notes that CGM data is still being evaluated for its use in all types of pregnancy-related diabetes. One of the other a rep that I had spoken to often talks about the use of their CGM for pregnancy. as I mentioned, pregnant women, we're just poked and prodded throughout that entire time. And so to add finger stick, it's just one more thing. And it's quite time intensive. And the most important thing that you mentioned is it's not catching the fluctuations throughout the day. And they're huge. And when I tried this one out, and I remember one night I was out with my team and we were up late and they went to a fast food chain nearby and I was like, get me fries. My glucose spiked from those fries. I know I have to always have protein first. Again, I'm not pregnant, but I learned a lot from this. There's other things I learned from it as well. So I would recommend, if anyone's just curious, get one of those over the counter ones and try it out and see how it changes whether you're pregnant or not. For those who are pregnant, the guidelines are saying still do the finger sticks, but we do have this other resource that is just really, really, from my experience and from others that I've spoken to, a really phenomenal resource. And I think it will come to time, hopefully soon, that ACOG and the ADA are going to say that we no longer have to do finger sticks in these patients. ADA does say it recommends CGM for pregnant individuals with type 1, but not yet for type 2 or gestational. So thank you for adding that. I'm always so curious when new technology comes about, and we're all on our smartphones all the time, and you can monitor that. And I know how often the CGMs are updated does vary by which brand. Again, it's not like a stick in the morning or later in the day or hour before, 2 hours after you eat to monitor that. It just seems like such an antiquated way to look at sugar levels. Any last pieces of wisdom you'd have for somebody either who's deciding to become pregnant or are pregnant or recovering from a gestational diabetes that you would like to add?
Yeah, I mean, I would say the big action item is screen, right? In terms of everyone has to be their own health advocate for a whole host of pieces, right? As you mentioned, it's pregnant individuals get pricked or prodded all the time. I think the big takeaway and the action item for individuals who, again, are in that planning pregnancy, in pregnancy, even postpartum, right? Get screened for type 1 diabetes. If something is off, bring up the conversation for monogenic diabetes. Really getting that right diagnosis in just gets you to the next step, so much easier.
And Todd, I thank you so much. If anyone would want to connect with you or learn more about your work, what's the best way for them to reach you?
Yeah, LinkedIn is the best way. Just search for me, Todd Vartanian. Best way to connect is there.
Thank you so much. And for everyone listening, I hope you learned something from our conversation today on diabetes, being pregnant or not. So much new information coming out. Tade, thank you again. Keep us updated on the clinical trials, new information. And we know we're in a day and age right now where it might be a little bit difficult to get truth, factual, evidence-based information. And I myself, and I'm going to speak on our listeners, we are just grateful for the work you are doing. Thank you again.
Thank you.